Good morning, everyone. I'm Betsy Cole-Archer with the Virginia Hospital and Healthcare Association, and I'd like to welcome you to today's live recording of our presentation entitled Shifting Our Mindset, the Role of NICU Staff as Trainers and Coaches. I wanted to share with you a couple of quick announcements before we begin. This initiative is funded by the Virginia Board for People with Disabilities. Today's session is being recorded and will be shared on the VHHA website. Please utilize the chat or questions feature of the GoToWebinar platform to interact with our speaker, but all questions will be held until the conclusion of the presentation. And with that, I'd like to turn it over to Kelly Walsh-Hill. Kelly?
Good morning, everyone. As Betsy indicated, my name is Kelly Hill, and I've been a pediatric PT for 32 years in Virginia. I currently work in both the NICU and as an early intervention provider. And I'm also chair of the Virginia Interagency Coordinating Council. This webinar being recorded today is intended for NICU staff, hospital administrators, nurse managers, and physicians, but early intervention staff will find it very helpful as well as we talk about the transition from NICU to early intervention. I'm so excited to be meeting with you today to share and discuss the national trend towards family-centered developmental care in neonatal intensive care units and to introduce the On Your Way Skill Builder worksheets. I'm going to be sharing why it's important, how NICU staff are the key players in this changing role of care, and how coaching and mentoring provides continuity in linking the family to early intervention after discharge. The objectives are to understand the 7 neuroprotective core measures of caregiving, define family integrated care and understand the 10 principles of family-centered developmental care, understand how family-centered developmental care influences a baby's outcomes, describe the importance of the parent-staff relationship, and administer the On Your Way worksheets. In the area of disclaimers, I have no financial relationship with the nonprofit Hand to Hold NICU Parent Support Organization, but I will be showing one of their products at the end of our talk today. Sorry about that. So advancements in medical care in the last 20 years have resulted in being able to save babies born earlier and smaller. We've made great strides in saving lives. However, we continue to see many babies with compromised neurodevelopmental outcomes, ranging from visual and hearing loss to cognitive and motor impairments to social challenges. A recent review confirmed that even late preterm infants are not immune to developmental disabilities, especially in the cognitive domain. It is believed that babies born between 34 and 38 weeks gestation encounter neuronal mapping organization problems associated with stress, and that early environmental influences on the brain during critically sensitive developmental periods account for these adverse outcomes. We know that neuroplasticity is a human brain characteristic and that it peaks in early life during the period of most rapid brain growth. It is essential that a healing environment is created. So what more can we do? In 2013, Dr. Leslie Altmeyer and Dr. Raylene Phillips identified the neonatal integrative developmental care model using neuroprotective interventions as strategies to support optimal synaptic neural connections in order to promote development and prevent disabilities. Scientifically, we know that by reducing stress in the neonate, we decrease adrenaline and cortisol and increase dopamine, which chemically sets the stage for optimal synaptic neurotransmission. It is the repetition of positive experiences that creates strong pathways leading to optimal brain development. The framework for the interventions became the 7 neuroprotective core measures for family-centered developmental care. They include a healing environment, partnering with parents, positioning and handling, safeguarding sleep, minimizing stress and pain, protecting skin, and optimizing nutrition. All of these are represented in the On Your Way tool. By implementing neuroprotective strategies, we can reduce stress and protect the neonatal brain. More importantly, we can utilize a natural resource associated with clear, evidence-based neuroprotective outcomes by focusing attention on the family-infant relationship in neonatal care. There is a growing body of research that shows parental presence and the quality of the parent-infant attachment directly influences a child's outcomes. The short-term effects were improved physiologic stability and decreased stress, both of which are neuroprotective. Specifically, Boundy and Spiegelman and others screened 1,053 studies of Kangaroo care and neonatal outcomes, and the results were a 36% lower mortality rate, decreased sepsis, hypothermia, hypoglycemia, and increased oxygen saturation levels. We also saw lower pain, improved head circumference, and improved weight gain. The long-term effects of consistent parental presence include improved attachment and bonding, optimal brain development, and enhanced physical, cognitive, and psychosocial development. Parental presence matters. In August of this year, Columbia reported the results of the first long-term controlled study on skin-to-skin care, also known as Kangaroo care. Skin-to-skin care is a method where the mother places the baby on her chest with direct skin-to-skin contact shortly after birth and continues this daily. The initial study was started in 1993 and ran to 1996 and had over 1,000 participants in two groups, the Kangaroo Mother Care Group and a control group. They found that 20 years later, studying 69% of the original participants, the effects of Kangaroo Mother Care on IQ and home environment were still present in the most fragile individuals. Kangaroo Mother Care parents were more protective and nurturing, and this was reflected by reduced school absenteeism, reduced hyperactivity, aggressiveness, externalization, and socio-deviant conduct of young adults. Neuroimaging showed a larger volume of the left caudate nucleus in the Kangaroo Mother Care group compared to the control group. The caudate nucleus plays a vital role in how the brain learns, specifically in the storing and processing of memories. Communication skills are thought to be controlled by the left caudate nucleus. This study indicates that Kangaroo Mother Care had significant, long-lasting social and behavioral protective effects 20 years after the intervention. In another study done in 2015 and 16, Lobo found decreased maternal touch in early infancy leads to decreased mapping in the brain. And a new hot-off-the-press study from Milan studying the effect of maternal touch on oral motor feeding in neonates less than 32 weeks showed the earlier Kangaroo Mother Care was introduced and the earlier parents fed their baby, the lower the post-menstrual age of the baby when 100% oral feeds was attained. Parental touch matters. So what is family integrated care? There is a paradigm shift occurring now that focuses on broadening the family-infant relationship in the NICU. The purpose of family integrated care is to enhance the bonds of attachment between parents and their baby. The medical team can save lives, but optimal physical, cognitive, and emotional development only occurs within the context of loving interactions with parents. In family integrated care, the physical and emotional well-being of the family unit is a guiding concern. It's based on the premise that parenting should begin as soon as possible, that separation from their baby should be limited, and it places greater emphasis on the partnership between family and staff. Family integrated care encompasses 6 areas of potentially better practices published by the National Perinatal Association in conjunction with recommendations from the Vermont Oxford Network and other parent and professional organizations. They include family-centered developmental care, mental health professionals, peer-to-peer and family support, palliative and bereavement care, post-discharge follow-up, and staff education and support. While we recognize the importance and intent of each potentially better practice, we respect that hospitals around the state will have varying capacity to meet all 6 of these areas. And for the purpose of our grant, We're going to focus today on family-centered developmental care, staff education and support, and post-discharge follow-up. Looking at the first three principles of family-centered care, we see the first one is providing antenatal counseling when maternal or fetal conditions are identified that could lead to a NICU stay. In my hospital, we have a family-centered NASC care program where the neonatologists and OBGYNs have established a partnership to identify moms testing positive to substances that may cause withdrawal. And once identified, the mother is referred to our neo team for a prenatal visit to learn about our protocol, what to expect, and how we partner with moms if their baby does wind up going through withdrawal. I know that Winchester Medical Center also has a similar family-centered NASC care program. So I understand that this may not be a relationship that your doctors share where you are, but certainly the second two principles are attainable in any NICU, providing families with a warm and culturally appropriate welcome, and treating parents as partners in the NICU caregiving team. And studies show that the recommendations can be achieved even in an open bay design while still complying with the security and safety rules of your unit. The family-centered concept is based on the partnership established between the medical team and the baby's parents and family. It's about creating a healing environment that welcomes parents. This is the first neuroprotective measure. We must take the initiative in providing reassurance to the family that their presence, opinions, and insights about their baby, as well as their active participation in their baby's care, are essential to achieving the best possible outcomes. And this is also the guiding principle in early intervention philosophy. This involves a shift in our mindset of our traditional role paradigm. Within the FCDC culture, we evolved from being experts to coaches and mentors and facilitate shared decision-making. Professionals have the clear medical knowledge and clinical expertise in deciding what is medically best for the baby, and parents rely on this knowledge. However, in a NICU parent survey, parents indicated they felt like they had to ask permission to care for their baby. We must look at a partnership between staff and family that's built on mutual respect, where parents are not treated as visitors. With family-centered developmental care, parents are expected to provide their own valued input to care plans, consistent with the clinical status of the baby. The relationship the bedside nurse forms with the family is particularly relevant because families often consider the nurse to be their primary means of information. Agard and Hall described the facilitative nurse as kind, helpful, patient, answering questions, and reassuring parents. Inhibitive nurses fail to identify and respect the needs of the parent-infant relationship and consider infants to be their babies who must be safeguarded against inexperienced parents. Communication at the bedside goes beyond providing details of the baby's condition to providing education about how parents can be effectively involved in their baby's care. Communication with NICU staff should be frequent, attentive, respectful, interdisciplinary, culturally effective, and using parent-friendly terminology. Parents report they want physicians to be direct but sensitive. They appreciate being given time to react and share their feelings. And after being fully informed of choices, parents desire to be involved in shared decision-making about their baby's care. We must acknowledge that parents are the most important people in their baby's life and provide reassurance that we are able and willing to support them in their parenting role. This is consistent with early intervention philosophy as well. Principles 4 and 5 focus on staff training and the utilization and collaboration with other disciplines. Healthcare today has changed, and staff turnover is a reality on most units. Making sure that new nurses and therapists are trained in the family-centered approach is important. We can't assume that people know how to work in a family-centered care environment because it may not have been the culture of their previous work experience. We can't assume that all NICU staffers are knowledgeable in developmental care methods and techniques. We should provide ongoing training and support within our NICUs to ensure continuity and quality care. In family-centered developmental care, individuals don't function within their own silo of practice. They operate as a team. Sharing expertise and learning from each other results in improved care of the baby and family. This approach works directly to avoid miscommunication with families regarding the methods and techniques used in their baby's care. Many of us do two-person care on a daily basis, and using this opportunity to work with another discipline is valuable. Sharing why you're doing something and asking questions make all of us better professionals. As the developmental care specialist on my unit, I'm very aware that I am only as effective for that baby and family as my relationship is with my team. Understanding the protocols and listening to the opinions of the respiratory therapist, bedside nurse, and neonatologist help us come to a consensus on a plan of care. When parents are able to observe this team approach, it fosters a sense of confidence and offers credibility to our coaching and mentoring process. It tells them we're all on the same page. And it also creates a bridge to early intervention, which utilizes a lot of interdisciplinary and transdisciplinary concepts. Continuing to look at family-centered developmental care, we see the terms mentoring and coaching parents in the area of neuroprotective care, helping them learn developmentally appropriate caregiving skills, recognizing the cues of stress, relaxation, hunger, and feeding. It also includes providing written information about skin-to-skin, bathing, and other calming and relaxation techniques. For the purpose of clarification, we're going to define the terms coach and mentor. A coach trains, instructs, and teaches. And a mentor is an experienced and trusted advisor. They advise and train. Through coaching and mentoring, we're able to incrementally increase parent engagement in their baby's care, as the clinical status indicates. This is the goal and final principle of family-centered developmental care. When we're looking at the transition of care from staff to parent, many NICU staff are doing the first two steps really well. We model or demonstrate methods and techniques, and we provide training and/or written education or visual tools for parents and caregivers. But we fall somewhat short in the next part of the process, where parents perform the skills and we advise, supervise, and encourage. We continue to do the care instead of letting the parent do it. Or we wait until the last part of the baby's stay before we expect the parents to take over the care, and then it's a crash course. Parents express frustration on not having enough time to practice skills and get feedback while they're still in the NICU. They want the opportunity to be able to practice the methods and techniques under your guidance and expertise. This is where our task-oriented behavior needs to expand to include parent practice throughout the NICU stay. By gradually increasing parent engagement in the care of their baby, it doesn't diminish your need, it enhances it. Parents want your support, and they need to hear that they're doing a good job. Being sensitive to learning styles is important. Mentoring includes anticipating and providing support for parents' expected anxieties and emotional distress. The NICU is an intimidating environment, and even the most educated parents find themselves overwhelmed in this world that we walk in every day. We shouldn't assume how quickly someone is learning. Parents may be sleep-deprived or anxious, which affects listening and remembering. Remember, they need the opportunity to practice in order to gain competence and confidence. If they seem hesitant, don't say you will do it for them. This is the moment to support and encourage. We should approach every parent with an attitude that they are valued. Avoiding stereotypes, bias, and judgment will break down barriers. An understanding of families' customs and beliefs will help us individualize our coaching. Coaching and mentoring verbal communication should be direct, honest, and bidirectional. Avoid yes/no questions. Instead, ask open-ended questions, such as, how do you learn easiest? What skill do you want to focus on today? What are your concerns about going home? I want you to be able to use these skills when you get home during a typical day. What's your usual routine? They may share information that helps you understand their world. For example, are they a single parent? Do they have to return to work outside the home? Will the baby go to daycare or have in-home support? Do they have customs that will impact the daily care of the baby, such as during bathing or feeding? Do they have other children or extended family members living in the home? Any insight into their daily life can help guide your recommendations while being respectful and supportive. And we know that the newborn is likely going to change many routines when they get home because babies are like that. But by asking open-ended questions, you get parents and caregivers thinking about going home, which offers hope and starts transition in their minds. Be aware of your nonverbal communication. In another study, sitting next to a parent or caregiver instead of over them resulted in increased parent attendance in the NICU. Some parents are going to establish a personal relationship with some staff over others, especially if they're there for a long time. This may be due simply to when they come each day, or possibly who they feel a connection with based on personality. But through the use of the skill builder sheets, all NICU staff can be coaches and mentors. The ideas and skills are the central focus, not the person delivering the message. If you have a lot of experience or special training in a particular area, you can expand on the instruction, providing any additional tricks and tips that you feel would be beneficial. One of the revisions that we're going to be making on the On Your Way tool is to add a comment section after each developmental area where specific adaptations and modifications can be added to customize the information for families. This brings us to our On Your Way Family Skill Builder tool. Now, those of you who work in early intervention won't be implementing this tool directly, but by familiarizing yourself with it, you'll be able to partner more effectively with your referring hospitals. The tool starts with a welcome letter that conveys a message of inclusion and participation. The focus is on how parents are needed as partners in their baby's healing process, and reinforces the importance of practicing the skills with staff support. The family-centered developmental care guiding principles and neuroprotective core measures served as our framework. Current neuroprotective interventions and strategies became our developmental methods and techniques to create a coaching program in an easy format. Guidance on this project was assisted by the NICU Parent Support Organization, Hand to Hold. And it was developed in a generic way to guide NICU staff on key components of each skill area while deliberately trying not to overwhelm with too many words and too many skills. With each skill building area, you're going to see that the first part talks from the baby's perspective, and then helpful developmental methods and techniques are listed. Pictures were provided for almost each developmental area. Finally, there's a section where the parent is able to identify that they learned the skill, practiced it, and now feel confident in using it. Staff and parents sign off and date. Signing off holds us accountable to using the tool as it is intended. This is not designed to be a discharge planning tool. It's meant to be introduced at the time of NICU admission and utilized throughout the NICU stay as the clinical status of the baby permits. Now, in the interest of brevity, I was not able to show all of the pictures that are in the On Your Way tool within this webinar, but we're going to go over each developmental area, the methods and techniques, so you'll be able to get a sense of how it works. And later, the tool will actually also be on the website, so you can use this in conjunction with the webinar. First, we focused on teaching a parent to read their baby's stress cues with a simple positive-negative chart. A description of how each body part might look was listed, and pictures were used to show babies showing negative cues versus babies in a positive, calming state. And it may seem like common sense to us as NICU professionals, but parents, especially new parents, aren't always aware of the more subtle signs of stress and how to help their baby feel better. So we got pretty specific here on the positive cues that they might see in their baby's face, mouth, hands, or body, some movements and actions that their baby might show, and then in the next column, the negative cues. And next, we provided simple calming strategies. Remember, the first goal of neuroprotection is to create a healing environment. So we want parents to be able to recognize stress cues and help their baby calm or relax. These include giving them a finger to hold, swaddling or containing me, holding me and talking to me softly, changing my position, or giving me a pacifier. Some of these techniques are further described in other sections. We encourage every parent to start their visit by talking with their NICU team that day and observing their baby to see how they feel. When a parent's able to identify how their baby is feeling, then they're able to decide what other methods and techniques they can use that day. The next area is sleeping, which is so critical to brain development and state regulation. So we emphasize here that when you arrive and your baby is sleeping, not to wake them. State regulation is the ability to maintain basic physiological body processes such as temperature, respiratory rate, heart rate, and oxygen saturation levels without much effort. It is achieving homeostasis. And when a baby is spending all of its energy on state regulation, nothing else matters. And it's so important for them to be able to sleep and rest. We know that many babies in the NICU can appear to be sleeping, but they remain in a dozing or light sleep mode. So we explain to the parents here what's happening, what important brain functions are happening during sleep, and then what they can do to promote it. Turning the lights and sounds down around the bedside, offering the baby a pacifier because sucking is calming and helps the baby self-soothe, helping the baby feel contained using nesting or swaddling, and making sure that they are warm. When parents know how to manage their baby's environmental space to aid sleep, it's empowering. They are being protective, and that helps them feel like parents. In the area of touching, we just emphasize here for the baby, nothing feels better than touching and feeling their mom and dad or caregiver. It helps them bond, relax, and know that you're there to take care of me. But understand that my skin is sensitive, so touching me too lightly will bother me. I like gentle pressure better. Providing guidance and instruction on the amount of pressure and varying techniques they can use aids in healing. So ways to connect through touch would be, again, grasping a finger in the palm, skin to skin, and we really talk about dads doing this too. And then talking about a technique called manual containment, where when the parent enters and comes up to the bedside, that they put a hand on the top of the head and on the baby's bottom and give some gentle pressure for about 20 to 30 seconds, talking to the baby quietly and helping prepare them for some interaction. You can imagine if you're in your bedroom, the lights are off, you're under the covers, and somebody comes in and whips the light on, pulls the covers off, and starts shaking you. It'd be a little unnerving. So we really want to help parents approach their baby very slowly and by giving that manual containment. And then also using massage. This can be very therapeutic for our premature babies or any even full-term babies. And we do talk here about being instructed by someone certified in neonatal massage, because it is a little bit different than traditional infant massage. As clinicians, we can nurture, but the emotional connection conveyed to babies when they're touched and held by their parents isn't something we can duplicate. Next area is positioning and handling. If I'm in one position for too long, my skin, shoulders, and hips hurt. My head might get flat on one side because my skull is soft. If I stretch my arms and legs out, I'm not strong enough to pull them back in. And when my arms and legs are close to my body, I'm more organized and happy. The focus here is on keeping the baby's arms and legs towards the midline of their trunk using either a nesting device or swaddle. We explain that positioners are not to be used at home in the baby's bed, and we encourage position changes to be done slowly and recognize that this will often need to be a two-person event to manage tubes and wires. We also have a section on smelling where we emphasize how sensitive the baby's sense of smell is, and that parents and caregivers should avoid strong perfumes or smoke or any other strong scent. But we do encourage parents to use the scent cloth on their skin so that they can then leave it in the crib or the isolette for their baby when they have to leave and go home for a while. As the baby begins to heal and grow, parental engagement can increase. The baby can maybe manage a little bit more stimulation. But in the area of looking, we talk about how immature vision is and how the NICU is visually overwhelming. So strategies focus on protecting vision, dimming the lights around the crib, covering the isolette with a blanket, or shielding the baby's eyes when the parent might be holding them. With listening, we explain that the baby can hear them and they know their parent's voice. We talk about how soft sounds can be soothing when the baby is awake and how sometimes music can also be helpful. The parent talking or humming to the baby, or even just reading them a story, can be very soothing. Even using background noise called white noise, like a fan humming, a heart beating, or a motor running, can also be calming and soothing for the baby. But we also emphasize that babies can't sleep and rest when phones are going off, or when people are having conversations that are loud, or sudden noises that are startling, such as keys rattling around, or even a person laughing out loud. So we really talk about also respecting babies when they're trying to sleep, and that would be the time to step outside. In the next area, we explain what cluster care is and why it's used in the NICU. Here we talk about where the nurses take care of me by doing a bunch of tasks when I wake up. And this means taking temperature, checking blood pressure, changing the baby's diaper, giving medicine, and maybe changing their position. And this is called cluster care. And if the baby's able to eat, this usually happens around a feeding time. And this way, afterwards, I can rest for a longer period of time without being woken up. These are all tasks that parents will be doing at home. So learning from nursing staff about cluster care is terrific. In my NICU, we have a family-centered NAS care program, and moms room in to help their baby with withdrawal. And they're taught how to provide all of their baby's cluster care except giving medication. So it really helps them feel involved and empowered. The next area is feeding. And here we start off talking about when the baby might not be ready to eat by mouth and they're going to have a tube going through their nose or their mouth down into their stomach. But parents can still participate during tube feedings and promote bonding by holding their baby and using a pacifier so the baby can begin to associate sucking with feeling full and have this be a positive experience. In the next area, we provide a few hunger cues that parents can identify, such as when the baby begins to wake up and smack their lips together, suck on their hands or pacifier, or turn their mouth to the side to search for food, which is the rooting reflex. When the doctor says I'm ready to eat, I need to go slow at first. Feeding is one of the most challenging aspects of developmental care in the NICU. It's a lot of work to learn how to suck, swallow, and breathe. This is a complex task developmentally and behaviorally and requires active engagement from the infant and the family. It requires patience and practice for both. Where one baby does great, another baby struggles. And this can be very upsetting for parents because it often lengthens the hospital stay when the baby can't eat and gain weight efficiently. Different hospitals have different philosophies related to feeding, so this area's methods and techniques were left very broad. We just talked about that the baby might need a slower flow nipple, a special bottle, fortified breast milk, maybe a different type of formula if they're going to be formula fed, a therapist to evaluate them and teach the parent special ways to help the baby pace so they don't tire out, choke, or spit up, or maybe a lactation specialist to work with the mom on pumping breast milk. So if possible later on, they might be able to breastfeed. It's important for parents to understand that feeding is an evolving process where some methods and techniques may be used for a while and then changed based on the baby's response. This is true in early intervention feeding as well. Coaching methods and strategies are meant to be changed as a reflection of developmental progress. Supporting parents in feeding their infants, even in the early stages of the process, is critical to building confidence and competence. The next slide that I want to talk about are parent rewards. And we talked back in the summer in the Change Package webinar about providing some meaningful way to motivate and reward parents. And so I wanted to introduce the NICU Milestone Bead Program that Hand to Hold established. They have beads that come on a chain, and they have two different packages. One is a short-term stay, which is a stork welcome bead, and then 5 additional beads get added as the parent is able to participate and learn these skills. The first hold, the first bath, first diaper change, first bottle, and then going home. The long-term stay one does also include the stork welcome bead and the 5 short-term stay beads, and then potentially 13 more, ranging from pound by pound as the baby's gaining weight, kangaroo care when they move to room air, first clothes, an open crib, a sibling visit. And these are really nice quality necklaces with the beads. Each bead has a small card that accompanies it and would really be a nice keepsake. And I know that budgets are tight everywhere, but if you have the capability of accessing any kind of funds, these would just be a really nice motivating reward system for parents in the NICU. And as a nonprofit, any proceeds will go directly to helping NICU families receive care and support. And I do know that Hand to Hold can also customize their bead programs for specific hospitals, and a PDF of their ordering form and contact information will also be provided on the website. And in development now, that's going to be the last page of the On Your Way tool, is going to be a final page called Going Home. This can be a time of great joy and also apprehension for parents and caregivers. So we explain early intervention and the supports and services that families can receive after discharge. We talk about the referral process, eligibility, and how the early intervention plan will also be family-centered, working to help them help their baby. There will be a specific line at the bottom where the program that provides services where that family lives can be listed, as well as the phone and contact information. In conclusion, by using the worksheets to establish a family-centered model of care and building coaching and mentoring into your daily tasks, you will establish a continuity of care that will help families transition to early intervention. By communicating and partnering with parents, you will equip them with powerful tools to get them on their way, and you'll be saving brains. My last 2 slides include references, and I want to thank you for your time today, and especially your dedication. to helping NICU babies and their families. Thank you very much.
Thank you, Kelly. That was a great presentation. At this time, we do have some time reserved for the audience members who joined the live recording to ask any questions of Kelly or of myself, Betsy, as part of the collaborative. So want to hold just a couple minutes for questions and answers. As a reminder, if you do have a question for either Kelly or myself, you may type your question into the questions portion of the GoToWebinar platform. And we'll give folks just a couple minutes to locate the questions portion and ask any. Well, I'm not seeing any questions come in the queue, so at this time, we'll go ahead and conclude the webinar. Thank you, everyone, for joining us, and thanks again, Kelly.
Thank you.